Good evening and welcome to Out in Left Field, a Green Monster production for Biddeford Public Access Television. My name is Matt Height. My co-host is Richard Rames, and he's making me laugh.
I am not.
Our guests tonight are Ed Bender and Eugenia Edmonds. Ed is the president of the student chapter of the Physicians for a National Health Plan. Eugenia is the treasurer, and they're both first year medical students at UNE-COM. And we're going to be talking about things like single payer and you know, the chapter they've just formed of Physicians for a National Health Plan. But first, if Ed and Eugenia, whoever wants to go first, could you just tell our viewers something about yourselves and you know, why you're at UNE as medical students?
Sure. So for me, I wanted to become a doctor because I found the science interesting, but I was more interested in all the different avenues that I could take with those tools and with those skills. And so I got an MPH, and while getting an MPH, I studied policy.
MPH?
It's a Master's of Public Health.
Okay.
And it gives you the opportunity to do a bunch of different things. So you could go down the route of epidemiology and look at the study of diseases and population, or go the complete other direction and work as a community engagement specialist and work with communities to address health issues. And in between, then there's the opportunity for policy. Mm-hmm. So I spent a lot of time on kind of that left-turnmost end of the spectrum doing community engagement and health policy. And going the doctor route became kind of, you know, just another part of that equation. Mm-hmm. Because in the end, my principal interest is working with the individual and helping to make them healthy. But if I see something going on with a number of people in the community, being able to then take that back with the knowledge that I have and speak with those that are calling the shots or making the decisions and say, this needs to be fixed.
Mm-hmm. Where are you from?
I'm originally from Rochester, New York.
Okay. Great. Eugene?
I am originally from New York, outside of New York City, and
what town?
Chappaqua, Westchester. We probably, no, Chappaqua. I actually grew up partly in the city, partly in Chappaqua, partly in Pleasantville.
Oh, so you're kind of a dazzling urbanite.
Yeah, I don't know about that, but I moved around a little bit, and it's a very nice, peaceful, safe town to grow up in. Mm-hmm. And I went to my undergrad in Michigan. And I actually lived out in Oregon for several years before I moved back to Brooklyn to live near my dad and my little brother. And I sort of went through a few different jobs and career possibilities, but I think I was always sort of interested in science and motivated to be involved with people and involved with the community. And it gradually came together as like this full package of how I could put all the things together that I wanted to do. So I went back and did the classes so I could apply to medical school, and because I had done music and psychology in my undergrad. And then I got into UNE, which I was really excited about because I did think it would be amazing to come to Maine. And when I lived out in Oregon, I was actually out in the country, and I loved being in a smaller place and a little bit different culture from the culture I grew up in. Mm-hmm. And
So are you guys kind of non-traditional med students?
A little bit.
It sounds like you are, certainly. You weren't just on the academic thing, treadmill, right, and just did your undergraduate and then right into med school, bam.
No. We're both on the older end of the spectrum in terms of, I think our average age for our class is 26, which is a little bit older than some schools, but
first year's at 26.
Yeah. And that fits the national paradigm, though. I mean, oftentimes you can see a lot of the allopathic and osteopathic schools that the average age of students entering medical school now is currently, I think, about 25 to 27, depending on the school, which actually correlates with better indices for satisfaction on the part of the physician and also satisfaction on the part of the patients, because it gives the opportunity for some more
broader world experience.
Yeah.
Yeah. Yeah. Yeah, it's kind of my experience going to college was that all I'd done was go to school for 12 years and then another 4, and man, I wanted to really do something else, but there was the draft, so I couldn't. So you didn't have that problem.
No.
Yeah.
So, but this is really, I mean, we were talking before the camera started rolling here. I mean, this is kind of a meat grinder academically. I mean, this is heavy duty stuff to be diving into in your mid-20s, and I mean, how you coping?
Early 30s.
Okay.
So your brain's already shrinking.
Actually, there have been recent studies that show that the concept of brain plasticity isn't nearly as cut and dry as they used to think it was. And even into your 70s and 80s, you still have the opportunity to develop new skills and create new neural networks.
So I don't have that excuse anymore? Is that?
You do. You're not going to be as on the ball as, say, your 6-year-old nephew, but you still, I mean, there's still some hope. You know, I'm still holding out for hope that when I'm 80, I'll remember how to tie my shoes and where I put my car keys.
Yeah. But my nephews and nieces are about your age, so.
Yeah. Okay, so you guys, you wander into med school here at UNE, and but part of the reason why you're here tonight is because, unlike maybe at least some, maybe most of the med school students at UNE, you've taken on this other challenge to be advocates for a particular reform of what passes for a healthcare system in the United States. So what led you down that path?
Do you want to go first? Or? So for me, what really cemented my interest in health policy, and especially in single payer, was largely based on just experiences that I had while in undergrad, and did a few ethics classes that started to open my eyes to how things were done and kind of helped me to cement my beliefs on, I guess, what I would consider to be human rights and what I would consider to be things that could be, I guess, set to the side, and help me to prioritize those things. And then I was lucky enough to take a few classes with someone who then became my mentor when I was doing my MPH, who was an American medical historian focusing on the last century and the development of healthcare in this country. And through taking courses with him and his emphasis on things, I really started to get a better understanding of how we got here, and also kind of what would make the most sense, and certainly isn't the system that we currently have. Because the way that it currently exists, it's largely been a hodgepodge. It'd be kind of, there's a Johnny Cash song, I think, One Piece at a Time, and it describes building a Cadillac out of parts that are smuggled out of a factory one year as it goes, and you kind of end up with a cacophony that falls apart as it drives down the street. That's kind of the healthcare system that we have, is that we've just kind of spackled together things as the years have gone on, and if something falls off, we take some duct tape out and hope that it sticks on, and unfortunately that's great, but we still have a bunch of people jogging beside the car hoping to get in, and it's not doing what we need it to. And for me, what really cemented that was then becoming involved with PNHP back in the Rochester area and helping to reopen the chapter that was there, along with some other physicians and the medical historian that I was talking about, and a few other MPHs that were there, and really learning more about the savings that would be offered through a single payer plan, and also the fact that it would include everyone, and that it wouldn't have to be inconceivable with this American notion of freedom and individuality, that you can still blend those two together perfectly fine.
And actually, I think the argument can be made that it actually enhances that freedom and individuality, because you're not under the thumb of your employer.
Sure. Or your insurer, for that matter.
Right.
Even worse. Eugenia?
Yeah. I think for me, I'm still learning a lot of the history and the details from Ed. But I think I started getting more politically active as I got older, and I just came to I guess most people do, right?
Less than
but
you'd
when
think,
I-
apparently.
But I think that the single payer, I didn't know too much about it, but I generally got to this point where I thought it just makes sense to me in an overall moral way to
Yeah.
offer health care to everybody.
Mhm.
And then as I learned more about the costs and learned more about the details of the current system and what the other options that people were coming up with or suggesting, it just seems like that's the only way to really to make it a fair system.
Yeah.
And to make it a moral system, I guess.
Well, the moral imperative, which you guys both have raised, I think that is kind of fundamental, and really the United States is an outlier in the rest of the world. I mean, last time I checked, it was us and Somalia, or I mean, there are basically no advanced or industrial nations that don't have a universal health care program
of some derivation. Sure.
Right.
It may not be exactly single payer, but there's some provision for care.
Right.
And well, you mentioned, you used the phrase human rights in I took it in your context, within the context of how you came to be a single payer advocate. Can you talk about that, how that fits into that context?
The idea of it being a human right?
Yeah.
Well, it's the basic provision. I mean, part of what I find perplexing about the notion that health insurance is something that needs to be purchased and is something that can be commoditized, like car insurance, is that it's a bit different. I mean, you don't necessarily plan that you're going to succumb to some bacterial infection, or that you're going to get into a car accident and become horribly disfigured and require months worth of care in the ICU or anything else of that nature. And so, to me, I see it as just it's like having clean air or clean water or basic provisions in Maslow's hierarchy of needs at the very bottom of the pyramid, to be able to guarantee that you can have your basic needs met, make sure that you can live have a good quality of life that accounts for basic medical provisions, so that you don't have to make that Faustian bargain or that decision between having food for your family and being able to go to see the doctor. And there's all sorts of ways that you can finagle that in a system, so that if people are concerned about covering everything, then you can say, okay, we'll cover these, but if you want to go to the fancy hospital with the new carpeting and the player piano, that costs a little extra. But I mean, the basic notion, I think, still stands, that as human beings we need to have some way of ensuring that we stay alive, that we have some of these basic needs met, and then we're not walking around with a peg leg and a patch over our eye if we can help it.
Could you use the Maslow's
hierarchy of needs?
Yeah, of needs, yeah. Can you explain that a little bit?
Do you want to?
No, you will.
It's your big chance.
Yeah, right. I remember learning that, but I don't think I could actually.
So the basic notion that Abraham Maslow had in describing this theory of the hierarchy of needs was that there are basic things that we as human beings need, and once we have those, and it works in a pyramid system, and if you have certain needs met, then you're able to accomplish the next level. And so, the basic needs are shelter, food, water, protection, safety. Insofar as those are taken care of, then you can move on to the next level. And each time you're able to make those needs met in the pyramid, you can move up to the next level. And the concept is, by having the various levels taken care of, you're able to better actualize yourself, make the better use of your resources, further your development as a human being. And so you can see that in history, whether that's the dawn of the Industrial Revolution and freeing up time for relaxation and leisure, or anything else like that.
So the less of your time and energy, fending off dangers and scratching for food,
exactly,
the more you can attain as a human being.
Exactly. And so healthcare factors into that, just because it's another thing that,
well, if you're in pain or or you're sick, it's pretty hard to attain any higher level.
And under the current system that we have, at least as it exists in America, it becomes a challenge for people, because many people defer seeing their physician. And unfortunately, with with many conditions, that means that it just gets worse, and that ups the cost and makes things more difficult on them. So even just looking at it from the economic standpoint, it makes it difficult, and that adds another burden to another part of that hierarchy.
Well, also, I hate to bring it up in polite company, but since the late 40s, there has been this document called the Universal Declaration of Human Rights, that largely sponsored by Eleanor Roosevelt. She was one of the chief protagonists for it. And the rest of the world has even gone further than that and actually implemented legislation and policy that undergirds that, but it basically speaks directly to this matter about the sort of basic needs of people in advanced societies and how we're going to meet those basic needs. Right. And that we shouldn't be arguing about whether or not some kids go to bed hungry every night. That's a basic right. What's the point of civilization if we can't meet these needs collectively? I said that bad word, collectively, but that's what societies tend to do in what passed for the modern world. I think we're heading backwards now, but that's another program. So
I'll come back for that.
So all right. So when you guys graduate from UNE, what then? And I'm going to get to the cost question here, but so what do you? What kind of career track do you guys have in mind?
Well, I am definitely interested in primary care. A big thing that when I was thinking about medicine in general, was the concept of not only settling in a community and getting to know the community members, but having long-term relationships with my patients and caring for different generations and being able to have that very personal and holistic connection to them and to the family in a way that I feel like really augments my ability to give them good medical care. So I do think that being a good physician is more than just the physical pain or the physical troubles that people have. And so for me, although I do hear a lot of people say, well, if you're ever going to get out of debt or if you want to do the big fancy stuff, you have to do this.
You've got to be a specialist.
Or that it's really, I may get more experience and find some area that seems different. I have been told that generally med students change their mind about 3 times before they actually pick what they're going to do, and oftentimes they go in thinking one thing and then.
Well, at this point, you're only indentured a small amount compared to the amount you're going to be indentured by the end, and
compared to the amount in the end. But
you're probably only on the hook for about 100,000 at this point, right?
Yeah, or so.
So that may impact your thinking somewhat.
Well, but I think that's sort of my trajectory.
Okay,
at this
that's
point.
what you think now. And I guess, let me ask, because you're going to UNE, which is an osteopathic medical college, and my understanding is that osteopathy tends to focus on, I'm sure there are specialties within it, but osteopaths tend, I thought, to go more into the GP stuff.
Yeah, I think in osteopathy an osteopathic physician can do any specialty that is out there, but the overall focus, and this is something that I also looked at a lot when I was applying to different schools, that I loved the idea that the way we're taught to come at a patient, I mean, not in a very aggressive way, but to sort of to interact.
Good evening.
But to really, to interpret the situation and try to help them is a very whole person, and this idea of not just giving them pills or giving them even a diagnosis, but actually working with them and talking with them about how their body can do a lot of healing on its own, and that we're here to make a plan. The 2 of us or however many people are involved in the room, that will support their health and their healing, and that their body is ready to take on as well.
I mean, I'm sort of struck by, the way you describe your ambition seems You know, I mean, it seems wonderful, but it seems counter to things I hear about the reality of the medical industry today. And I'm wondering, what are your prospects of actually being able to realize this ideal, I wonder?
Well, she said she's got 2 more mind changes coming.
Well, I'm sort of I honestly don't know. But I will say that I generally, especially with the different things I've done in my life, that I find that I just have to do the best I can, like just make the plan and go for it.
Mm-hmm.
And even if it's hard for me to imagine how it's really going to work in the end, especially financially, I hear a lot of different things, actually. I mean, I don't hear anyone saying, "Oh, don't worry, you won't end up with any debt," but I hear some people say, you know, if you are interested in working with underserved populations or with the rural communities, which both of those are definitely interests of mine, or if you're interested in doing this or that there are a lot of specific hospitals or areas or programs and things that can help. And so I think at the same time, when they say that, I'm not going to be accessing any of that for another 6 years or so. So I won't, they may or may not be there when I get there, which is a pretty intense thing to think about, that it really is, and not to mention the entire healthcare system could and very likely will be in a pretty different situation. So.
And that, I guess that's another thought is I mean, what changes are needed in order for you to realize that ideal, perhaps, is another way to look at it.
Yeah, that's
Well, that's what we're going to talk about, I think, as we go. Hey, so Ed, what about you? I mean,
I would say that I'm on a similar page with Eugenia. What really, when I started wanting to be a physician back at the tender age of 15, for me it was more about just the opportunity to continue learning about the human body and interact with somebody else, and if they have something wrong with them, fix that, and that seemed cool. But as I got older, what enticed me more was the prospect of actually being with someone as they were dealing with things, helping them out to relieve their suffering, or in the instance when it's something that isn't treatable, to be there for palliation, to help them through those things, to be with them during times that society currently sometimes pigeonholes them and puts them away. And to me that was really enticing, and one of the things that draws me most to primary care, at least as I currently see it, unless I can find some way to make billions of dollars and still feel like I'm making a difference and, you know, being involved in someone's life, was the concept of being there with them, having a relationship, watching as they went through their life and being part of that, and helping and using that to help me to make a better diagnosis. I mean, there's a big push now in the medical community for medical homes, which is principally just this idea that you have someone that is helping to kind of call the shots, that's effectively not only your physician or nurse practitioner, but also your advocate, someone that's there to say, right, so you saw the specialist this day and he wrote you this prescription, but then you saw the cardiologist this day and she wrote you this prescription, and those two seem to conflict. Let's work on this. Let's talk about this.
So that role is the general practitioner who kind of sees the whole playing field,
right,
and can be the arbiter of the different specialties as they bear on the patient.
Absolutely.
Okay. So, I mean, one of the interesting things, the way the advocacy field for single payer has evolved, it seems like right now, even in Maine, from what I understand, the general practitioners are pretty well down with single payer.
Yes.
It's the specialists that still are fighting the rear guard action from the 30s. Not all of them, but there's more resistance to single payer from the specialists. And also, it seems as though the day of the country doc where a doctor could have a practice and, you know, basically just with the doc or maybe a secretary, that those days are long gone because of the complex billing arrangements, and, you know, that's why a lot of docs are going to work for these HMOs and stuff. Could you talk about that?
So one of the things that I can speak to, a case study, I mean, one of the first things you learn in public health, first things you learn in medical school is you cannot extrapolate from a case study that carries forth to all examples. So just because it happens with this person doesn't mean it can happen nationwide or in every instance.
Okay.
But I have a close colleague who I actually met through the PNHP chapter in Rochester, who graduated from her family medicine residency back in 2008, and she's opened her own practice, and she does it exactly as she wants to. She has time to meet with patients for anywhere from 30 minutes to an hour, and she does this by having someone that comes in to assist with billing only for about 15 hours a week, and uses technology to basically help to close up the gaps and everything else. And it doesn't mean that she is slacking off. No, she works, she works incredibly hard, especially as a mother of 3 young children, but she's able to prioritize what she wants as a provider and is able to make it happen. Do I think that it should exist that way? I think we could improve upon things. I don't think it needs to be a sort of deal with the devil, so that if you want to be a primary care provider, you have to subscribe to the notion that you have exactly 10 or 15 minutes with a patient and that's it, and that you have to work in a huge monolithic organization where you as a provider and they as a patient exist as a number or a faceless mass. But
yeah, but isn't that the dominant thing now? The individual practitioner in his or her own office tends to be, as near as I can tell, tends to be a dying breed.
yes.
Yeah, I have heard a lot about, actually I recently did a preceptorship. We go for an afternoon and shadow doctors, local, sort of somewhat
Okay.
local sometimes, and just watch what they do and learn from them. And recently I shadowed a physician who had his own practice for 30 years and finally decided that he just couldn't make ends meet anymore because he kept having all of the paperwork, the different insurance paperwork, and the technology updates and things like that and the medical records, like the electronic medical records and things like that. And he said it was basically, he just got an offer he couldn't refuse because it took all of this stuff that was kind of draining the money
down,
and said, oh, well, we'll just sort of we'll just take care of that. We pay your rent and we get all of that stuff in a streamlined manner. That we have people who do that for all of the doctors, and so it cuts down the cost by that much. And he's like, he said it's much easier now. It was very hard for me to leave, but it's much easier for me to.
Well, it's easier, but I mean, I would say two things. This is somebody who's come in from the cold, who probably had most of his debt retired from medical school, so he wasn't looking at the overwhelming debt burden that you guys are going to likely be facing. And 2, I mean, we don't know what kind of a patient load he was taking on in this new practice. I mean, I think it's hard to buck these HMO or these preferred provider systems where it's more or less, from what I understand, kind of like a treadmill. I mean, those patients are coming in every 15 or 20 minutes. That's the model, and you've got to deal with that. If you've got a lot of clout, maybe you can negotiate more patient face time. I don't know how it works, but that's the sense I'm getting. Does that seem
That's close to my understanding of how things work, unfortunately. And my understanding, albeit somewhat limited, is that unfortunately, even in the countries that I would hope that we could, in terms of economics and provision per care, to emulate, it seems to be somewhat similar as well. That there are certain constraints that are placed. It's certainly not as bad, but in having studied the system in the UK, it's something similar. I mean, it's not nearly as strict, but they tend to be restricted to between 15 and 20 minutes with patients unless there's some reason not to, and then it's often that the physician at the end of the day will have to go back to the office manager and basically plead their case, present evidence as if in a court of law as to why they needed to have that additional time and why they messed up the schedule for the rest of the day.
Yeah, but the National Health Service is not the model that we're talking about with a single-payer system.
No,
I mean,
because that's a
under the
socialized
single-payer
system,
thing, like in Canada, the docs are independent contractors, essentially.
Right. And certainly one of the things that would certainly make life easier if we were to look at a single-payer system like Canada is that, in the instance that Eugenia was describing, individual providers are struggling with the burden of having to fill out, the mountains of paperwork that are required for taking care of patients.
To all the different payers.
Yes, and if you can streamline that into being one payer, one person that you have to file paperwork for, will it mean that we won't have paperwork? No, of course not. Paperwork's inevitable, like death and taxes, but you won't have to fill out duplicate forms for Excelis and Blue Cross and Cigna and Humana and all these other folks. It'll just be one going straight to the entity that
To the single
pays.
payer.
Yes.
But you also won't have to be dealing with an entire bureaucracy that's designed to deny payment.
Yeah.
In a single payer system. Generally that's not the way it works because you've taken the profit motive out of it.
Right.
Whereas in the private health insurance model, there's a profit motive to deny care. And if you're not fighting that as a physician,
Right. Then you're doing your patients a disservice. But if you're fighting that, you spend. I can speak from my experience.
what I mean is when you don't have to fight that in a single payer system,
Right, exactly.
you're freeing up lots of energy and
money. Currently we spend.
that can be focused on healthcare instead of.
We spend 31 cents on every healthcare dollar that's spent in this country on paying for the administrative overhead of these insurers to basically then justify why they're denying a patient care. So if we can cut that out, that's 31 cents on every single dollar that can be used towards patients to cover care, to pay for basic needs.
To, pay for educating doctors and so that they don't go into
Absolutely.
practice.
Oh, happy day. And then we woke up.
For those viewers that just tuned in, you are watching Out in Left Field, a Green Monster production for Biddeford Public Access Television. My name is Matt Height. My co-host is Richard Rames, Dennis Ryu behind the camera. Our guests tonight are Ed Bender and Eugenia Edmonds. Ed is the president and Eugenia the treasurer of the local chapter, student chapter of Physicians for a National Health Plan. We're talking about why they got into being doctors and why they've become politically active in advocating for a single payer healthcare system. Now we're all sitting here talking about single payer as though it's inevitable, which I guess I believe that it is. But since the early 90s, we've had these serial attempts to, as I see it, forestall single payer and to, build in the insurance companies more solidly. Build this profit motive in and build in revenue in the system for these private entities. So, can you talk about at all the recent Health Care Act and what's going on in the Supreme Court right now and all that sort of stuff, and where is this going to lead? What are the shortcomings? What are the benefits? Where's it going to lead?
Would you like to talk at all?
You should start.
Okay.
Well, you have a lot more of the numbers, I think, and the facts than I generally do.
The more recent stuff has been a bit harder to follow as I've been immersed in the life of a first year. But currently, with where things stand with PPACA, which is the Patient Portability and Affordable Care Act, or
Patient Protection.
Patient Protection.
That's what they call it.
You can also hear it referred to as portability at
really?
times. Yeah.
Okay.
But if you're a member of those that sit on the right, then you refer to it as Obamacare.
Actually, I think everyone is referring it to Obamacare now.
Yeah.
He's taken it there.
Even PNHP is referring to it that way to some extent.
Fun.
Yeah.
Okay. Well.
Even Obama, I think they're trying to neutralize it.
Taking it back? They're
Well,
taking the term back?
Yeah, taking
okay.
it back. Can't
Okay.
beat him, join him.
Okay. Fair enough. But yeah, so with Obamacare, PPACA, whatever you want to call it, the general notion was that it was, again, a piecemeal approach to try to address the issues that currently exist in the healthcare system. And it started off with promise. It went through the process that all political bills do in our system, where good things go to die on Capitol Hill, and it came out still pretty aggressive and radical in some measures in its scope, but in terms of what it's done to truly address the issue of access and coverage, it's kind of missed the mark. And so this issue currently that's being discussed in the Supreme Court is largely centered around this notion of the individual mandate and forcing people to go and buy, forcing them to buy insurance as an individual, that you don't
To buy defective products.
Right. That you're forcing them to purchase private insurance, basically.
That won't provide much coverage.
Right, but it's based on, it's the problem when you're approaching an issue from the ivory tower standpoint. So from the stance of health policy, from the stance of what the literature says, for health insurance to work, everyone has to pay in, basically. It doesn't work if everyone's not on the same page. So in theory, they're approaching it just from the standpoint of, if everybody's paid in, then that's going to bring down costs, and this current system that we have, where people are where the U.S. is spending $8,000 per person each year on health care based on GDP projections, that's going to help to bring that down. So we'll find cost savings in forcing people to pay for the health insurance.
That's what it works out to, $8,000 a person?
It's projected by 2020 that we will be spending, I believe, 20% of our GDP on health care.
Right.
And it works out to be approximately, I think, $7,600 and some odd dollars per person per year, versus the UK, where it's, at least back in 2010, it was 3,600. In Canada, it's 3,200 or something.
Yeah. We're spending roughly twice what other industrial or advanced countries spend.
Right.
Getting worse outcomes by
Right, much worse.
37th on the WHO health indices from 2005 versus, let's see, that fearsome, frightening pinko commie country of Denmark, where people are #1 for healthcare, or Sweden, where they're #2, or the UK, where they're 10th, or Canada, where they're 9th. And
So, but my understanding, I mean, you said that one of the guiding principles of this was that everybody was going to be covered, but the government's own figures indicate that somewhere between 20 or 28 million people will still be uncovered.
Well, I said it would work on paper. I didn't say it was going to work in practice. It was something good to fly a flag with, but
But I mean, I don't know. It seems to me that one of the central problems is that is the profit motive. Okay, that the profit motive drives decisions, and outcomes don't. Good outcomes for patients don't. I mean, that seems like one of the central problems, and PPACA does absolutely nothing to remedy that. It seems like it actually tries to sort of get more revenue for the private companies and build them into the system.
It mandates that, essentially. I mean, you're driving people to pay and providing government subsidies for people who don't make enough money to afford these outrageous premiums. The government will step in and offer subsidies to the insurance companies for the insurance companies to cover these people with these defective products. And as Steffi Woolhandler, one of the founders of PNHP, has been saying right along, that in many ways this makes the problem worse, because the reason that we can't get to a civilized system is because of the power of the insurance companies, and this is going to roll yet more billions of dollars every year into their political war chests to make them even more powerful as political adversaries. It's not clear how we get further if we're enriching the forces of reaction. Does that make sense? Or?
No, it definitely does. I was just reading some things about the Supreme Court arguments that they're having right now, and what was interesting is they were talking about the individual mandate, and they were talking about whether that's constitutional and not forcing people, how, there's this big issue of whether you can force somebody to buy something and what the limitation is, because then are you going to force them, what else are you going to force them to buy in the future?
Broccoli.
And yeah. But the argument that came out from the side that is against the individual mandate is that, it would be fine if you just had the government paying for health care.
Right, right.
But if it were just a tax, but you can't make people buy it. And they were saying, in some ways that's such an odd argument for that side to present. And I was listening to a show on the radio about it where they were sort of saying what would the positive or negative outcomes be in terms of if it got passed, or if they accepted the individual mandate or they didn't, who would it would motivate a lot of both sides in some ways, either way, and that there may be some motivation if they don't pass the individual mandate and they don't
They overturn it.
They overturn it, thank you. And certainly if they throw out the whole law, or even if they don't throw it out, and they allow some of it to stand, that they may go back, and depending on who's reelected, obviously, we know what's going to happen if Obama's not reelected, but if he is reelected, that they may say, okay, now, let's just do it. We need to do this a completely different way, because we've been told that it's not constitutional to have the individual mandate, so maybe that possibility will be back on the table.
Well, I mean, as I understand it, the Physicians for National Health Program's basic position is that regardless of what happens at the Supreme Court level, and regardless what happens, even if the individual mandate is passed, that regardless of what happens, this PPACA thing is not going to fix the essential problems with what passes for the American healthcare system. Something else is going to happen. The question is how many more people are going to have to die while we figure it out. And currently, the numbers that we've heard from Julie Pease, the president of the Maine All Care, is that something like 45,000 people die every year in this country now because they don't have access to health care. Therefore, they get sicker than they should, and by the time they finally are so sick they go to the hospital, they're unsavable, or they have a much diminished and shorter life.
Right.
And yet the country stands here. Apparently, I'm not sure how many people know about these statistics, and after all, they are just numbers.
Right.
But it seems to me that there's a great acceptance in this country, more so than in other countries, I think, of death and suffering. It's just as American as apple pie.
In the name of profit.
Yeah.
A certain callousness in American life, despite all the maudlin, lovey-dovey talk. I mean, these are shocking numbers, basically.
But there's also a long history, not to say that other countries haven't struggled with this, but there's also a long history of those that have a vested interest in the current system that does deny people care, that does, lead people to spend a fortune on a defective product. They stand threatened if that way of life is undermined. And so it's existed for, goodness, I mean, as far back as the turn of the 20th century, that there have been vested interests doing everything in their power to not only argue against it, but help to sway the American public to see things differently, or to not necessarily see all the facts that are on the table and only see a selected few. And they've gotten very good at honing their skills since the 1940s and 50s, when they were, arguing against the precursors to Medicare.
On the other hand, I mean, I've mentioned this before on shows, people who come here from other countries, and I've seen it myself. I was taping a show in Portland one time outside of a congressman's office, and there happened to be a guided tour that was going on, and a bunch of German hospital types, administrators, happened to be walking down the street in the Old Port. And the host, just pigeonholed. He didn't know who they were. He just pigeonholed them, and it turned out there were these German hospital administrators. And so we got into this little impromptu discussion about the state of what passes for healthcare policy in the United States, and they were plainly shocked You know, they couldn't, you know, we have heard that you do this, but we can't believe it. You know, because in Germany, you know, everybody gets the same treatment. That's what he said. Whether you are rich, whether you are poor, it's all treated the same, right? Whereas in this country, people from away, they come here and you drive around on any average American street and you see sick people walking around. The state of public health is not good in the United States. And it's as obvious as just walking or driving down any street in the United States. And yet this passes for normal and it's deemed to be acceptable.
Given that, can you talk about this, the WHO indices and
What they were based on, and
well, what they are, and like where we
Where we rank.
where
What's
we
our
are.
report card?
well, so the WHO indices, as far as I understood,
What's the
it-
WHO?
The WHO is the World Health Organization. It's isn't it a branch
It's the UN,
originally
I
of
think.
the UN?
Yeah, I think so.
And it's basically kind of the be-all end-all of public health and health issues in the world. I mean, I think it rivals the CDC. The CDC, they kind of jockey for position in where they stand, but they're both.
Well, CDC is a national organization.
Right,
Yeah.
right, but that's kind of what I'm saying. I mean, as a national organization, CDC is still respected worldwide, but the
okay.
WHO, they're both kind of, they're doing their thing, and the CDC being national doesn't have the scope that the WHO does. And
Right.
they, as part of their mission, and also addressing certain aspects of the other branches of the UN, will address the current state of health in the countries across the world. And I'm not sure, I haven't seen the most recent index. I'm sure that they probably have a newer one, but I know in 2005 they did an all-inclusive, huge survey where they looked at all the nations of the world, and they ranked them based on infant mortality and morbidity, the rates of certain chronic diseases, access to care,
Life expectancy.
yeah, all of these sorts of things. And in the end, they then ranked the countries, and the countries that came out first were, as I was rattling off before, Denmark and Sweden and the UK and Canada and Germany and France.
Norway must be way
Yeah,
up there.
yeah. And then countries that were getting a little bit closer to the bottom, you had, I think, Swaziland, and I'm pretty sure, I think Slovenia came in 36th.
I think Slovenia's ahead
Yeah.
of us.
Yes, that's what I was
Yeah,
saying. And,
yeah,
and the
yeah.
US was 37th.
Yeah. Yeah. But we're still ahead of Sudan, maybe? We're ahead
true.
of...
It's true. We
We're ahead
haven't
of
been-
Afghanistan.
Yes.
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 We're not ahead of where Iraq used to be.
Right.
We're ahead of where Iraq is now, though. Mission accomplished.
If you can't redefine things, if you can't redo the system, just break a few pots and you'll be
Yeah,
fine.
yeah. And a few bones.
Yeah.
Works really well.
Yeah.
Yeah. Yeah. Well, again, I mean, this is not just like that, you know, statistic that I talked about, the excess death statistic. That's out there. If there was a powerful movement to make social change, that number would be common currency. I think most people have not heard that number. Folks are not invited to think about that number and what it means. And in the same way, this ranking of where the United States actually is, we're encouraged to believe that we have the best medical system in the world, and we do if you're part of the 1% or maybe the top 5 or 10%.
I think it's also interesting. We just watched Sicko for the first time the other night, and in that, which was made in 2007, I
Yes.
think, he's citing that there was 18,000 premature deaths due to health insurance in 2007. Now we're talking about 45,000.
Right.
So I think that gives a pretty good indication of the trajectory of our system and where it's going.
Yeah. Yeah. Well, there may be slightly different modalities too. I mean, that the number 18,000, that was based on the Institutes for Health study, and they used census data and some other things. And then the Urban League, apparently, they updated that a couple of years after, I think, the Institutes for Health came out. And now there's another organization. And like I say, Julie Pease and she sent me the citations, and these numbers are available on the PNHP website if you'd like, and it's a really good website, you ought to go there. They do all this bean counting, and it's a really good place to get your information. If you want to develop some talking points to come down and talk to the city council about, or your state legislator, it'd be a good place to go. But these numbers are, you know, are there to be discovered, to be thought about, and to be used in political discourse. If we only had a political class that was willing to do that, or a press that was willing to do it. One of the
or
things yeah, well, you can lead the horse to water, but can't make him drink. One of the things you talked about, the initial stages of the PPACA legislation. Let's not forget that when it was just in committee hearing, that there were two consecutive days where a bunch of docs and nurses and public health professionals wound up getting dragged out of the meeting room, including Dr. Flowers. Well, there were a bunch of doctors and nurses. Could you talk a little bit about that? And
sure. And
that kind of breaking the mold a little bit.
Well, they were basically advocating. They were trying to bring awareness to this concept of single payer, because during even the small committee hearings, that wasn't even being discussed.
Right.
The closest they were coming was a public option, or something that was a little bit more
an undefined public
right,
option.
right. So it was something that was a little bit more vaguely inclusive, but it wasn't specified, and from its very inception, it was already somewhat more in the centrist position, and so it was less likely that something was going to be a really drastic change. They weren't taking it as far over as they could and then letting the slingshot come back. They were taking it only about halfway and leaving it unspecified, and even that became something that was considered too volatile, and they took it off the table. And so this group of physicians and nurses basically coalesced, and they spoke up during these hearings, and were arrested for trying to raise this point, trying to take advocacy to the committee when the committee wasn't listening, and did their part to try to raise awareness. And I know that certainly Dr. Flowers has taken that in other ways. So it was 2 years ago, I think, where she brought it. President Obama had made a State of the Union address, and in it he was talking about the recent legislation that had been passed as part of in PPACA, and that if anybody had any ideas for change, that he invited them to bring them to him. And so she showed up the next day, because she's a pediatrician working in DC. She showed up the next day with a series of a packet of information based on statistics, and showed up at the White House and said, "Hi, I'm here to meet with President Obama," and managed to get herself arrested again in that instance. But basically, she's trying with one of the only avenues left, as far as I can see, to try to raise awareness, to try to make a blip.
That being civil disobedience and direct action?
Yeah, I think to some extent, because there's so few options that seem to be available, given that I think we as Americans have become to some degree numb. I mean, when you were asking earlier about how can people accept where things are, it's part of accommodation. Then, you know, as the human nervous system, you don't notice the fact that you have your shirt on because you just adjust to it over time. I think as deplorable of things have ended up becoming, we become desensitized to it. There's just a way that in order to live, to get through the day, you just start phasing it out.
Well, I mean, you know, women got the vote in this country not because the Congress decided it was a good idea, but a bunch of Margaret Flowerses decided that it was time to go on hunger strikes and to be civilly disobedient in front of public buildings and so forth. So they got put in prison, they got force fed, and they just heightened the contradictions. And you know, I mean, individually, that was pretty powerful. I think it was the Bacchus 7 the first day, or I don't know.
Bacchus 8, I believe.
8, okay. Yes. But individually, for people who didn't see it, Margaret Flowers and others, I think most of the ones who got arrested were either docs or nurses. They basically stood up and said, basically, single payer ought to be on the table, not off the table. And they had a series of statements that they read, and one person would stand up, start talking. They would come for them, they would lead them out, they're talking over their shoulder, trying to get as much out as they could, and then as soon as that person was out, the next person would stand up and continue where that last person left off.
Right.
And I should say, by the way, when Julie Pease was on the show before, she talked about how Margaret Flowers is coming to the state.
And
Do you know the date?
It's May 10th, and actually that's something that I'm excited about because we've managed to finagle Dr. Flowers to come and speak at UNE for...
At the Biddeford campus?
Yes, for
Oh.
lunchtime on the 10th.
Oh.
So...
April 10th?
May 10th.
May 10th.
And so normally such talks are geared towards medical students, and you have a few people that show up just because they're looking for free food. But
Yeah.
this is the opportunity to have Dr. Flowers come and speak to us as students and to the community at large about pushing for, advocating for change and talking to how to...
So this is open to the public then?
Yeah,
Yes.
it is open.
So maybe we can do a videotape of it.
That would be excellent.
It would be
I think we have to
excellent.
We have
get
to
some
probably
permissions
go
probably
through
for
some
that.
sort of red tape for the university.
Didn't
but-
used to, but maybe.
Well, it's easier to get forgiveness than permission.
I could always get arrested, I guess.
Yeah, right. They won't kick us out.
So, what are some of the other things that, what are some of the things that the student chapter of PNHP has in mind to do to advance the educational effort and the political efforts around single payer?
Well, I think one thing that I've been working a lot on actually is we have a course called Case-Based Learning,
Mhm.
and it's a really, I think, fantastic course that integrates a lot of the knowledge that we get from our other more intense science courses and clinical skills and all the different things. And so we sit down in small groups and we discuss a specific patient and what symptoms they have and what their medical history is, et cetera, et cetera. We go through the whole thing. And it's actually sort of a three-step process where we work on it in a very small group and then in a medium-sized group and then with our entire class, which is 125 people. And the goal is to not only look at the science from a bigger perspective and be able to apply it,
Mhm.
obviously, to something, but that we are going to be doing as opposed to problems. But also to get the big picture of the patient. And I
Mhm.
think what we've had several times is someone come in, there will be at least some aspect to the case that doesn't have to do with their specific illness,
Mhm.
their physical illness, that
Mhm.
they may have a problem with alcoholism or they may have a problem with various things, and so we have a discussion about that as well, or we have a speaker. Anyway, so one of our hopes is that we can actually get a case that is oriented towards specifically the issue of healthcare and health disparities, health insurance, and all of
Mhm,
that.
mhm.
I think because it's curriculum, we can't exactly insert something very political into there, such as single payer. But the goal is to get the student body in general, or our class, discussing all of the issues that come along with that.
Well, my
Being
understanding...
underinsured or uninsured.
Right.
Yeah, that
right.
we would present a patient or maybe two patients, and basically, we've talked about trying to have two different cases, that would be split up, and then one patient would have one type of health insurance or options versus the other
Mhm.
options, and basically what course their disease would take based on whether they had the money, the access
Mhm.
to the physician,
Mhm.
and whether they were able to afford their medications, and how long it took them to get to the initial appointment.
Well, the other thing, and I just want to bring this up in closing, I think it's on the PNHP website, based on this 45,000 people dying every year from delayed or absent care, that works out to be basically one person dying every 12 minutes. So while we've been taping this show, 4 or 5 people have died because they didn't have access to health care.
Right.
And that's, I thought, yesterday I was on some other guy's show, and I thought about bringing an egg timer, except I didn't have one, and set it up so it would go off every 12 minutes and say what that meant,
Yeah.
Wow.
Yeah.
But anyway,
Anyway, did you want to say something in closing, or, because
we're running out of
we are out
Right.
of time,
Understand.
and I want to thank you both for being our guests tonight.
Thank you.
Thank you for having us.
Ed Bender and Eugenia Edmonds, who are officers in the student chapter of the National Physicians for a National Health Plan. They've been our guests tonight. We've been talking about single payer and the healthcare system such as it is. For Richard Rames, this is Matt Height saying good night, and thank you to Dennis Ryu for shooting the show.